From coast to coast, experts from Stanford, MD Anderson, and the University of Miami share their insights into the world of head and neck cancer rehabilitation. Coming up next. Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia care. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for conversations aiming to bridge the gap in dysphagia education and practice. We value diversity in backgrounds and opinions, so our guests will not always reflect what we believe. Through critical reasoning and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. Welcome, everybody. I'm here today with three individuals who have something in common that you'll learn about a little bit later. We have a repeat guest, Dr. Carly Barbon from MD Anderson. We have Dr. Mario Landera from the University of Miami and Dr. Heather Starmer from Stanford University. And Carly, if I left it out, I didn't mean to, but yeah, Dr. Carly Barbon too. In case you felt left out, you did kind of earn that PhD. So it's good to be recognized for it. So let me throw this back to you all. What brings you together? Why these three particular nerds?
I think we're all a little bit crazy. And
all right.
I think, it's a good kind of crazy. I think we're very creative and, we have a passion for patients who have head and neck cancer.
And in case you all were wondering, that was Carly. I forgot to ask you to say your names first. That was Mario. This is Tim. And yeah, if Carly, Heather, you don't mind identifying yourself, that might be the more ambiguous one.
Okay. That's me, Carly. I agree with Tim. I think that, the uniqueness of the three of us, and I think just this, just general respect for practice and, research lines. Feel like Mario kind of brought us together and I'm very grateful for it. So Heather?
Yes, this is Heather. I agree. I think, these two people that I'm sharing this experience with tonight are expert clinicians and researchers. And I think that our shared love for head and neck and for doing it with a real patient focus with everything that we do is a real shared passion for all of us, that we really want to make things better for the patients. And so we do that through our clinical practice and we do it through our research. And education.
Yeah, absolutely. No, that's great when you get that practical lens from somebody, who knows the nuances of research and can control for variables and spot, things that are maybe influencing an outcome that an untrained individual might not, but you have a very solid clinical application and are grounded in why stuff matters, right? Not just measuring a 5 millimeter change in whatever it is, but you're grounded in the clinical work. I didn't give you really an opportunity to kind of like, hey, this is me and this is why you should believe me. Not that I don't think you need to defend yourselves, but let me throw it back over to Mario first, if you don't mind. Can you tell us a little bit about what you're doing and where you come from?
Yeah, so I am working at the University of Miami, the Department of Otolaryngology. I'm an associate professor on the clinical faculty track and chief of speech pathology. And I started half in more the laryngology clinic and half head and neck. And I did that for 9 years. And then the past 9 years, I've been more fully devoted to the head and neck cancer population. And it's been an absolute love of me. And I think, we'll share in a little bit as to why we love head and neck cancer patients.
Good deal. Heather, you want to go next?
Sure. Yeah. So I currently at Stanford University, as you mentioned, I am a clinical professor in the Department of Otolaryngology and also direct the outpatient head and neck speech and swallowing rehab program. And similar to Mario, before I was in this particular role, which I've been in for 11 years, I was at Johns Hopkins and I worked in a more general ENT practice. So half non-cancer voice and swallow and half head and neck. But I started working with head and neck patients in my externship in the University of Pittsburgh, working at the VA. And I just absolutely loved head and neck from my first experience with head and neck. And so I've been fortunate that my career is just sort of like continued to like funnel down more and more from like a super broad VA population to pretty much just working exclusively with head and neck cancer. So that's me.
Very cool. Carly, what about you?
I love these backgrounds. I'm an assistant professor, tenure track in the Department of Head and Neck Surgery at MD Anderson, and I come from Canada. So I have a pretty extensive research training, I guess. My undergrad was at a very research-heavy university in Canada. I then did my master's and fell in love with head and neck, actually, with a laryngectomy patient, my very first laryngectomy patient. So that got me just like on this trajectory of head and neck. I, did my PhD in Toronto, looking at pathophysiology in swallowing post-radiation, and really got into my kind of programmatic line of research now in oral cavity and glossectomy through one of the head and neck reconstructive surgeons that mentored me. So I feel like, kind of like Heather, it's interesting, like every step of the way, you're just kind of like led towards this path that draws you. And I feel really, really blessed. Ended up at Anderson for a postdoc and just stayed. And so, I think like it's so clear that the three of us also feel very lucky because I'm in clinic 60% of my days. And so I get to see patients and draw, my research questions from them. Like nothing better than that, in my opinion. So
Absolutely.
yeah.
Real life stuff.
Yeah.
And Tim, speaking about the patients that Carly was just talking about, I think the patients are so special. They're so unique, So I've been practicing for 18 years, if we did the math, when I was talking about 9 years and where I've been 9 years. So I have patients still from my first year that I'm still seeing. So, they were once talking to me about their children, and now they're showing me photos of their grandchildren, So the fact that we can develop these special relationships with them, I think is something that really drew me to these patients. I'm very much a family-oriented person. So these patients, they kind of all adopt me, or I should say I adopt them. And I think that is something that has made it, it makes it fun. If you have fun with your patients, then they're really not patients. And I think that's what, they want to know. And we treat them like a person. And I think that's the underlying reason that kind of drew me towards being more full-time in the head and neck clinic. And these patients don't need to be perfect. They are okay with being functional. As long as they can get their feeding tube out, they don't care. They'll do whatever it is. And I think that that's something that I kind of relate to. I just want to keep moving. And I think that they just want to do the same thing. So we got each other. That's that little craziness that I was talking about. That is important.
I feel like clinic days with you are probably very fun.
Oh yeah, I have a blast. Yes,
Yeah.
yes.
But it's easy to become too sterile. You think about, okay, this is all business. You're in a clinic setting. You want to make sure that you get everything about diagnostics. And actually, I think about this a lot when I'm working with students. They kind of they lose their personality. They go in there, they're very sterile, and it's like, I got to do this right. I got to do that right. And you got to kind of step back a little and be like, be yourself, right? These are people. They're going to connect to you and they're going to have so much more buy-in if they can connect to you as a person. And you have personal things that you can really draw upon to be unique and that are strengths. Like we're not this, automatron's doing this. AI hasn't taken our job yet. You still get the personality. And that is so, so important.
And, my patients have taught me that you have to live life to your fullest right now, not tomorrow, not in 5 years, so for me, it's all about the experiences. And I thank my patients every day. And that's why I'm like, okay, well, I'm going to go on all these trips now and I'm going to experience life. I'm going to try all these foods so that when I recommend certain foods, to my patients, I can say I've had it and I understand it, So I think that, I was a very picky eater for most of my life, and my patients taught me to eat.
I'm sorry, Mario. I just had to laugh out loud because all I can picture in my head was an experience of you trying a specific food in Tanzania this summer. You want to share with the people what you tried?
We need to know. The people need to know.
There are several things that I tried. I always will try things once. Are you talking about at the restaurant in Kenya?
No, no, no.
Oh, that one?
It was a mildly thick liquid
Yes.
that was comprised of.
Yes. So we went to go visit some of the tribal villages in Tanzania, and they have, as a custom, they will get cow blood and mix it with cow milk as a traditional ceremony. And Heather, myself, and one of our other friends were there, and we saw that they were so happy to show us their ceremony, and actually took them longer. And once they had it all ready, it was like, okay, who's going to be trying this? And I said, oh my gosh, this is kind of weird, but I'll do it, because if you guys do this, I want to be able to experience it and be in your shoes for 1 hour. And yeah, it was, it did taste like blood. I kind of think of myself when I was little, and I would get a cut on my finger and I would put it in and taste it, but yes, it was an IDSI one.
Slightly thick liquid.
Slightly thick liquid, yeah.
But like, there's got to be some good protein in that, right?
Yeah,
That's
Lots of iron.
That's what makes you a man, a warrior.
He can fight off a lion, and he can also do an MBS in 30 minutes flat.
That's right.
All right, I gotta throw out this very, very niche thing that probably no one's gonna know what I'm talking about. But for the 5 who do, they're gonna laugh. Have you seen Nacho Libre? And it's when he goes and gets okay. Well, he gets the eagle powers. The guy convinces him that to be the best luchador, he's got to climb and get the eagle eggs, and he eats the eagle egg, and then he like does an eagle dive off this cliff into the water, and it was all for the eagle powers. It didn't work for him, but I guess it's worked for Mario. So
it worked for me. Yeah,
it worked for Mario.
All right.
Everyone has a lion.
I ended up spending so much money on the gifts that they had, Heather. Maybe I shouldn't have drank that.
So as you all can tell, common ground in this area, head and neck cancer, working with patients with head and neck cancer pretty continually, lots of it. Some of the people who are listening will be of a similar background, but I'm going to venture to say that most of us dabble occasionally, that we intermittently get people coming through the door, and we are not specialists to the degree that you are. What advice do you have for people who, occasionally, once or twice a week, once or twice a month, have a patient who comes in with, I'm not even going to try to go out there. I was going to late radiation, this, that, whatever. But I'm curious, maybe one of you will have something different to say about even like a different population, because I know you all focus on different areas within head and neck cancer too.
Yeah, I'll start us off, because I think one of the big things that is really important for people who don't see this a lot is, number one, knowing that the risk factors in head and neck are very different than the risk factors for somebody with Parkinson's or ALS or dementia. And so whereas in other populations, we might be more conservative in our management, with head and neck, we tend to be a little bit less conservative, because our patients are young, they're up, they're walking, they're working. And so we don't need to be as conservative because the risk factors are not the same. And I think that's one sort of really critical thing, is that the shared decision making is probably one of the most important things with working with head and neck. Yep. Is understanding the risk profiles are different, and understanding that this is really a collaboration and a partnership. And like Mario said, we become family with these people, and it's because we sit down with them and we really understand what are their goals and what are their needs, and we work with them to try to accomplish that. So I think not being too scared, because some of our patients' swallows look real ugly, and we send them home eating, and that's okay because they're doing all right. So I think those are two of the things that I would say is shared decision making is huge. and don't be too conservative.
Can I actually ask you a follow-up question about the idea of not being too conservative with this population? And you mentioned that there are different risk factors that are, not so prominently. People are up and walking around, moving. They're typically not bedbound. And so those types of things are very positive prognostic indicators in terms of, at least pulmonary health and whatnot. Do you think also it's because you have to, but and I don't mean that like you're compromising, you shouldn't be doing that, because I really think it's more of the right thing to do. But because if you took a look, if you managed it maybe as sensitively as, not, how do I say this without pointing any fingers? Just as some of us may have 10, 15 years ago with our general patients with dysphagia. I mean, what everyone might be NPO or on thickened liquids or this and that, and it's not practical. Not only might it lead to like a lot of other negative outcomes, but I almost wonder if it's partially by necessity, but also that necessity forces us to focus on function, which I think is a wonderful thing.
Yeah, I think you're right. I think there's a practicality in that. When you've got somebody who's admitted to a hospital, you have a lot of control over their environment, what they're eating, what they're drinking, what the kitchen is going to bring them. When they go home, it doesn't matter if I tell them that they need to be on, mildly thick liquids. They're probably not going to do it. So instead of beating a dead horse, what do I need to do? I need to educate them on reducing their risk factors. I need to teach them how to do great oral hygiene. I need to teach them about keeping their lung function up and keeping, strong and robust. So I think there is certainly a degree of it that, when you've got outpatients that are young and healthy and very opinionated, you've got to work with them. You got to figure out what's the right thing to do.
I also do feel like, to tag on to that, a lot of the patients that we have that are non-compliant uh do really well. And so I found that, even as an early clinician, I would be a little more conservative. And with this population, it really is like on an individual basis. Like everyone is so wildly different. And I also think that the plans change like so much depending on what stage of their, presentation they're at, what stage of their treatment they're at. Like it's so non-linear with these patients that you can have a plan and it can, veer sideways depending on what's going on with their treatment plan, or, recurrence or wounds and things like that. Like it's just, they keep you on your toes. But I do think that, being flexible is really important for them. And the non-compliant ones tend to do well sometimes, which I hate saying, but it is true in my practice experience anyway.
Yeah. And Carly, I'd like to add to the non-compliant part, because those are the patients that have taught me the most, because that's when I'm like, wait a minute, you're doing what? Uh, look, do you mind if I see that in a fees? Or do you mind if you show me that, and we'll do an MBS and we'll look at it. And, instead of being that you're going to do it my way and the patient's going to do it their way, and we're so far apart, we can actually meet in the middle, so it can be where it's like, okay, I understand that you want to eat and you want to have that cheeseburger, but can you just do this one strategy for me? That's it. I'm not even going to give you exercises. Just do this one strategy, and that'll reduce the risk, of ending up in the hospital. And I think that once that happens, I think that's when the patient said, wow, you listened to me. And now I'm, in this part of the whole family dynamics, you listen to me. And then the next time I see them, I'll say, hey, now I want you to do this one other strategy. And we got there. And then I learned new techniques, new strategies that can be done. And then the patient now is compliant, so we figured a way to make it work. And I think that's where, mentioning before that we've all been alluding, we just want the patient to be functional.
Yeah.
I said to that point, I said to someone today in clinic, I said, like, you are driving. I'm just the GPS giving you direction. You can choose to veer off course. That's,
Yeah.
like, but really we are just there to guide. And I do think that some people figure things out on their own, sometimes like better than us, but we can lead them. I think it's really important to keep an open mind. It's a really good point, Mario. Yeah.
Mm-hmm.
There's so much that can come from this. Like earlier, I wanted to tangent about that idea of like, how does the body compensate? How does the body figure things out? Like we think we need to fix that thing, but how does another part of the swallow compensate? Like, I don't know, base of tongue retraction isn't great, so it's not doing its thing on the epiglottis, but your ariepiglottic folds approximating are just, compensating so well. Patients figure things out. But there is something else that I want to bring up that I think is invaluable that comes from this, because we think our inclination is humans in general are risk averse, right? We're not totally risk averse, but we tend to stay to the side that we're less likely to kill ourselves and kill somebody else, right? That's just, we don't want to hurt people. We don't help people. And so if you think of one, like a 0 is you're doing nothing that's of risk. And 100 is like you're Evel Knievel with a helmet off, like not wearing a helmet, like you're probably going to kick the bucket. I think we kind of creep up from the 1, the 2, the 3, the 4, because we want to kind of hug that conservative safe side as to not cause harm. But then you get patients who are non-adherent, non-compliant. They are going to go do what they want no matter what. And that forces us, if we're respecting their autonomy and their right for self-determinance, it's forcing us to see what happens, right? We're not giving them bad advice and we're saying, like, I think you should do this thing and it's going to kill you, whatever. But it forces things a little further in that direction, because I believe the risk is if we're just creeping like, back to this line, like a 0 is no risk, can go to 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And it's like, I don't know, the 16, that's going to be when someone gets pneumonia, or an 18. And then it's the 30 and then it's the 35. But this person's full blown, pedal to the metal, like I'm a 70, like I don't care. That's how I live. And then nothing happens to that person. And it's like, wow. This was a little different than I thought it was. And also, like with research too, that might not get through an IRB, right? But this case study, look at what you can derive from this case study of what happened with this, with this individual. No, I think it's super cool.
It's almost like a movie, to me, it's like, oh, this, you are the main actor or actress and I'm the director and I'm just here. I want to hear more. And I think that's what kind of makes it fun. And, and I don't see myself treating any other population than head and neck cancer.
Yeah. And I think the other thing I was just going to say is I think we as a field need to remember too that pneumonia is not the only risk that we're worried about, right? We're worried about deconditioning. So when we make these patients NPO, we are contributing to their dysphagia. And when we're not thinking about quality of life, the rate of depression, anxiety, and suicide are highest in head and neck cancer patients with dysphagia. Yeah. So why are we not talking about that? Why are we talking only about pneumonia when we've got people who are committing suicide? Like, there are other risks we need to be thinking about. So if we're not really letting the patient be the driver and being their GPS, right? Like we're missing out on other risks that are potentially much more important than what our textbooks taught us to think about.
Yeah. I wish I had a soundboard. I want to hit my mic drop button. It just, I don't know what that sounds like anyway, but yeah, absolutely. That is very, very valuable. It kind of takes us away from the tunnel vision of stuff.
Yeah. And I want to share an interesting case that I think the listeners will kind of appreciate, because I remember doing a pre-counseling for a patient that was going to get a total glossectomy, so the entire tongue removed, and a total laryngectomy. And everything was scheduled for this patient, but thankfully the patient came to see me to do an evaluation and counseling session. And after questioning, this patient loves food, this patient loves to talk. And when they heard what could happen afterwards, this patient said, you know what? You're the only one that asked me what is important for me. And because of that, I know that I would be miserable with this. So she ended up not getting the surgery, and she lived, it was less than 6 months. But as she was towards the end or the final weeks, I did get a message, and she said, "Thank you. I had a good time with my family the last few months, and I have no regrets not doing the surgery." And I think that was something that, to me, I was like, wow, we're supposed to be helping these patients, but if there's no quality of life, then we're doing a disservice to the patient. So I think the patients need to understand that. And I didn't realize the big impact that we can have, for something, situation like that. Yeah.
I mean, back to what Heather was talking about, the level of collaboration you get within this. And I mean, that story just exemplifies so much a step away from paternalistic medicine. And just we're not here to fix a car or a refrigerator or tell you got to do this, this, and that, or I'm going to write non-compliance stamped all over your note and you're going to, get kicked out of the whatever, that type of a thing. It's treating people as humans and not being arrogant and assuming that
And
they're going to
listening.
that they value what we do. What's that?
Yeah. And listening to them,
Yeah.
Mhm.
Yeah.
listening to them, asking them what their priorities are. Because if that surgery or
Yeah.
treatment match, it shouldn't be done.
Yeah. Are these their goals or our goals? Right?
Exactly.
They're their goals. This is about
Exactly.
them.
Yep.
I
Love
also
it.
think there's a lot of stuff that we don't talk to our patients about that they probably would like to talk about. I think having groups, like support groups, is something that I've been thinking a lot about lately. I had a patient of mine talk to a young patient in her 30s, talk to another patient in her 30s about both of them having total, subtotal glossectomies, and the entire room was crying. And I think there were things that I would have never thought about
Yeah.
that they were talking about, like the inability to sneeze and the fact that they, like spray secretions everywhere when they're sneezing and how that's really annoying to them and how they're like nervous to sneeze in public. Kissing, right? Like partners, those types of things that, you know, I've asked a couple of patients about before and they absolutely broke down. So I do think there is more to the picture that like we offer as just even support of quality of life. The more quality of life we can give them, like there are so many pieces to their puzzle every single day. So I'm very aware that when I give someone exercises, they are also brushing their teeth 10 times a day. They are using
Yep.
their, trays. They are doing their neck exercises. They are doing PT. It is like a laundry list. And I think like for me, thinking about, lifting as much of their quality of life and improving as much of their quality of life, because there are so many pieces that we don't even know about. And I have really thought lately about, support groups.
What would we miss out on? Like if we thought we could fix everything with exercises, like you do this exercise that I say and that versus thinking about the resources like that they can be for each other. I mean, we just can't do everything. And I think that's a humbling, incredibly
Mhm.
humbling story that shows, there's more than just swallow hard,
Yeah.
right?
Yeah.
And I think those of us who live in head and neck all of the time, we've learned that those things that we thought were the tools in our tool chest don't work often in this population.
Yeah.
So if you've got a patient with late rad, exercises are not going to, fix that problem.
Right.
So then you have to start thinking about what else is there? What else do I need to be thinking about? And how else can I make this situation better for the patient, the quality of life better for the patient?
Yeah.
And so I think we're sort of uniquely positioned in working with a population where the things we learned in graduate school don't work. So we have to do something different. We have to get creative. We have to see what they're doing. Like Mario said, if a patient's doing something weird, maybe it's going to help another patient too. So let's learn what that weird is.
Yeah.
Mhm. Almost like functional rehab, right?
Yeah.
They're like using their
Yeah.
function and making it work for them.
Yeah.
Yeah.
Yeah. Heather, I'm gonna, if it's okay, put you on the spot. You threw out a term, late rad, and I'm gonna assume that not everyone who's listening knows what that means.
Sure.
What how would you, in a nutshell, explain it to someone who maybe hasn't heard that term before?
Sure. Yeah, good point. So many patients will have side effects during radiation and the immediate time after radiation. So we consider those to be sort of acute effects. Some patients, probably less than 10% of patients who've had combination of chemotherapy and radiation, will develop problems many years after the fact. So it can be 2 years later, 5 years later, 20 years later. And what we tend to see is a progressive fibrosis and then cranial neuropathies as a result of the fibrosis. So they often present with hypoglossal palsy, vagal palsy, and pretty bad swallowing all around, as well as dysarthria and dysphonia. So it's sort of this surprise, you survived cancer, and now 15 years later, you're functionally completely decimated.
I'm glad I asked you that. I'm glad you all didn't ask me that because that was a beautiful explanation. Thank you.
Sure.
Thank you. All right. Well, I feel like we've been talking for 10 minutes. We've actually been talking for like 30 minutes, and that's not even including the pre-talk, right? So
Yes.
what I would like to ask you is maybe just some takeaway, a brief take-home point for clinicians. It could be for clinicians who work 9 to 5 every day with patients with head and neck cancer, or those who have a family member with head and neck cancer and never treat a patient. What are maybe a gem that you can each of you could leave our listeners with?
Yeah, I'm happy to start. I would say don't give up on your patients. Okay. Listen to your patients. It's not just about the good times. It's also, about, we still have a role as speech pathologists if there is a patient that has a disease that cannot be cured, and that's improving their quality of life at the end, and I think that those are very special moments. And, we can have a role with helping them communicate better or even swallowing a little bit to improve their quality of life, so never give up on your patients, be creative, and listen to your patients would be my 3 gems.
Huge. It's a whole bracelet full.
Yeah.
There you go.
Mario kind of took mine, but I was gonna say,
Jerk.
way to go, Mario. I'll elaborate. I was gonna say that hope is a real thing for these patients,
Yeah.
that I think, like honesty is very important and giving it to them straight because they will respect you a lot more if you tell them the truth.
Yeah.
You give them the risks, but you also offer them hope. And I think that there have been patients where small gains have like made an incredible life difference to people. And somebody coming for rehabilitation when everyone has told them that they may not be able to function in a way that they want, but yet if I can teach them compensations and they can speak better or swallow safer or more efficiently, like that's a gain. Even though the global picture isn't a change in their digest grade or there's not a change in their diet, like little gains are very, very meaningful for a lot of these patients that are people that, and at the end of the day, asking them, what is your goal? If your goal is to say your S is better, like let's try it, right? It's not my goal. It's yours at the end of the day. So I would say, hope is a really big thing, and I think you can have that while also being truthful. It's a balance. So
Carly, that's beautiful.
Testify.
That's why I love you.
thank you.
That's so true. So true. And since both of them stole everything I wanted to say, I'm gonna lead with a story. So there was a gentleman that I work with probably 20 years ago now, and this is a story of learn from your patients. He was a active duty in the Army. He came in to see me. Anybody who knows me knows I'm short. So when I say somebody's tall, it's not that big of a deal, but he was really tall. And in his combat fatigues, his combat boots, shaved head, super tough guy, worked in special forces. And I remember thinking, oh, well, this guy's super tough. He's going to make it through this treatment. Well, guess who ended up admitted to the hospital with a peg, with a trach, every possible side effect that could happen. And he came back to see me 2 months-ish after his radiation was over in a wheelchair. His woman was the first time I'd met her. And he said, in my line of work, you never leave a man on the battlefield. And for the past 2 months since I got discharged from radiation, I've been at home feeling like I was left behind. And I felt like somebody just put a spear through my heart. And I learned that we need to do a better job of preparing patients. So it completely changed the way that I prepare patients for that period of time after radiation.
Wow.
But a couple of years ago, I was prepping for a talk, and I told him I was telling our story yet again, because I always tell our story. And he said, there's part of the story that you're leaving out. And that part of the story is that the other important thing in my line of work is that you have a battle buddy. And your battle buddy watches over you and is making sure that you're getting what you need and taking care of you. And you are the one person who was my battle buddy. Mm-hmm. And so that really drove home to me the point that both Mario and Carly has made, that we have so much potential to help these people in different ways beyond the textbook things that we've learned, and the importance and meaningfulness of that to their lives. He and I still message each other, several times a year, and he's been out of treatment for 20 years. So yeah. I think that, really learning from our patients and finding that our failures are an opportunity to do better.
Ooh, I like that.
I love it.
Hitting heavy. Those are all very, very insightful. Well, thank you all very much. I am going to let everyone who's listening know at this point in time that is well, okay, first of all, thanks to Bracco, this, for at least a period of time after the episode is released, will be made available, or the plan is to make it available for continuing education credit. So it'll be about 30 minutes worth. You've gotten to that point. You are there. We are done with that stuff. You've fulfilled. You'll have to go and answer a few questions or write a reflection or do something else at the end. But just to let you know that this is the point. This is as far as you need to listen. Because I have something really exciting to tell you about. But I also, it can't require you to listen to this to get the Con Ed credit because there's a conflict of interest. But I really was going to smile from ear to ear. You can't see me, but I'm so happy. So Dr. Starmer, Dr. Barbon, Dr. Landera have been so generous to work with me. Well, I can't even say that. You all are it. They're doing a course that is basically a day in the clinic. They're going to go through multiple case studies. Mario's got some, Carly's got some, Heather's got the lunch and learn, and then there's a collaborative one at the end where they're all going to talk. It's going to be about like 6 hours. It's going to be fantastically remarkable. I'm so excited for it. I've been excited for it for a while because we've been talking about it, and just life has been chaos. And so really excited for that. Thank you again for being on here. I don't want to put you on the spot to say anything about why are you excited about this thing coming up? Feel free to, but don't feel like you have to, because it's just, I've been super impressed just with everything I've seen that y'all are putting together.
Yeah, we're excited about this. I think it's going to be fun. Be in the clinic with myself, Carly, and Heather, and this applies whether you see head and neck patients the entire day or just one patient every once in a while. I think that you'll get good information because we also, not only are we going to talk about different sites of cancer or subsites of head and neck cancer and how we can help them with their swallowing outcomes, but we're also going to have sub-themes, in these cases. And we're thinking about having this sub-theme be related to challenges, so whether it's a patient that challenges you, caregiver challenge, physician challenge, and SLP challenge. So we're going to use that theme in there that can apply to any kind of case, not just head and neck cancer. So I think you'll find this to be fun, informative, and yeah. Carly, you want to add some more?
I'm just really excited to, do this with you two. I think it's going to be a blast. So I think whoever joins us will, learn a lot, have a good time. I'm really excited for, it's going to be very, like you said, Mario, case-based and, just hang out in clinic with us. I'm excited. I think it's going to be great.
It's truly like from the East Coast to the West Coast. Mario, you're in Miami, and Heather, you're in Central Coastal California, right?
Yep,
And
yep.
then Carly, you're holding down the Gulf of Mexico and Houston, and I am by the Great Salt Lake,
Right.
and
Love it.
and you.
Four corners. Well, not quite, but
Yeah,
Carly can count for the Canadian northern corner too.
there
Okay,
you go.
perfect. Good. We cover it all.
Cover it all. Cool. Well, yeah, I'm super looking forward to that. And I am super excited for whenever this episode comes out, hopefully sooner than later. Thank you all so much. I would just sit here and flatter you for a while, but I'm not going to do that because it'll probably make you puke and the listeners puke. And I am so grateful. Thank you. I love these conversations. Look forward to keeping in touch and have a great rest of your week.
You as well.
Thank you for listening, and a big thank you to our guests. For a brief period of time, thanks to a sponsorship from Bracco Diagnostics, this episode will be available for ASHA CEUs. Go to swallowthegap.com/HNCPOD 2025 for more information. If you're interested in ASHA CEUs for this episode, you've come as far as you need to in terms of listening. But for those who are interested in diving deeper into head and neck cancer management, these 3 exceptional clinicians will be leading an advanced level 6-hour live webinar full of case studies and more on January 31st, 2026. This has been in the works for about a year and will immerse you into real-world clinical scenarios. For more information, visit swallowthegap.com/HNC, like head and neck cancer webinar. So swallowthegap.com/HNC webinar. Thanks again for tuning in. Thank you so much to our guests and hope to see you in January or maybe even sooner.